Hello, everybody. Warm greetings from MBR CanCon 2024. We are on our day two of our academic session. We have with us here Dr. Anil Vaidya. He is the Director, Institute of Multi-Visceral and Intestinal Transplant, Cleveland Clinic, USA. Welcome, Dr. Anil.
Thank you. Thanks very much. Thanks for having me here.
Dr. Anil Vaidya, do you think that transplant oncology is a very exciting branch in oncology?
I definitely think so. Not only think so, I know so, because we've come to a time where transplant techniques have gotten better, outcomes have gotten better. Surgical oncology is a fascinating field. Surgeons that come out from surgical oncology are super aggressive. The only rate limiting step is the inability to replace organs. So I think this is a fantastic interface between surgical oncology and transplant. So the tenets of transplant oncology are about how much can you take out. There's no limit to what you can take out. If there is no limit to what you can take out, because you know you can replace like for like, then curative options become a reality. So yes, I think we're at a very exciting part of our lives.
So the next thing, generally, what the public would want to know is there is generally a tenet that more radical the surgery, the quicker the patient will fail or a recurrence might happen. So does that hold true in all cases? And how should we approach when we are talking about transplant oncology as such? How should be our approach?
So I think the approach is quite. It's going to be a progression. It's not going to be the first option you're going to give patients that come through the door unless you have extensive data to support it. So this is like a marriage that it will progress to becoming a very happy marriage. I think the first referrals will always be the referrals that no one wants to touch, and therefore once you're embarking on something that's so new, you have to have rigid protocols. You've got to have an IRB in place. You've got to have ethics committee involved and structure it so that the patient is not at harm. Because you can imagine a person who's got a terrible cancer will coerce itself to having anything done. But you got to be absolutely sure that the patient understands what is involved in terms of you having a transplant oncology approach, and therefore you've got to put a few brakes on our excitement, because we have to make sure that the patients are served safely and in an appropriate fashion, and they understand, what this actually entails.
So, like you said, patient selection is a very key, vital step in this decision making of going for a transplant.
Absolutely. I mean, that is everything, patient selection. And not only that, I mean, patients need to understand, what they're up for. And in India, for example, there's also this financial burden that patients take on when they are embarking on a territory that's not been proved yet. So a lot of work has to be done, structured way of getting into this specialty, uh, a, a way of collating data that's anonymous as well as meaningful, so that we can actually learn from what we've done and then offer the services or not offer the services depending upon what the data suggests.
So, the now when we talk about transplant oncology, probably it in its infancy or is it's probably in its walking stages in the West.
That's a good question. I hadn't thought about that. For example, the first interface with oncology and transplantation has occurred, maybe 20, 25 years ago in GI transplants. For example, metastatic neuroendocrine tumors. People have resorted to multi-visceral transplants, and they've been very successful. And they've published a lot. So that's one specialty that we can outrightly say to your patient: you've got metastatic disease, transplantation might be an option. The other one is slow-growing desmoid tumors of the abdominal cavity. We've published, we've done it through proper channels, we've done it, we've got the data. Now we can boldly say, yes, this is an option for you. And that selection of that patient, we now know which patients will benefit from it. Pseudomyxoma, for example, now the latest kid on the block, we're still in our learning phase. Even in the West, we're still just about starting to get up from a crawling stage. So there's still time there that we will try to find out why we're having the different issues that we have after transplantation. So it's not a golden ticket, so to speak. It's an exchange of cards. You exchange your cancer cards for transplant cards, where you inherit transplant related issues.
So you earlier talked about financial burdens, and in a resource-limited setting like India, would you say like it's the time to jump into transplant oncology, or should we prioritize on other cases? But at the same time, another question is, should we have legislation for it, and should we have centers of excellence where transplant oncology should be done?
I think the last point really hits it on the head. I think not everyone should be doing this. I think to start off with, till we get enough data to be publish protocols and establish protocols, as well as demonstrate that we're successful with what we're doing, it should be limited to a few centers. There are centers of excellence in oncology, centers of excellence that can have a transplant program supporting them, as well as, I think that's the clinical part of it. I think that what you also need is a research arm that supports that clinical arm. So translational research is what's going to take us to the next level. So no, not everyone should be doing it, and it should not be a cowboy attitude to try and get into transplant oncology. It should be few centers who understand the process, have the infrastructure to put in the process, as well as understand the financial implications for their patients. And to be honest, if any center is going to take this up in a big way, there has to be ability to support patients during that journey through this specialty. So there are financial implications. The government has done a lot for transplantation by subsidizing transplantation. As look at liver transplants, 25 years ago, it wasn't paid by the government in India. Now each state's got a different allocation of funds for liver transplant, and if transplant oncology is going to hit that high note, I think that might require support from these
Government
agents.
funding is required to take it to the next step.
Yes,
especially in countries like India.
in countries like India, but the government won't get involved unless you show them some data.
Data.
And therefore, it's a chicken and egg story. But someone has to make that progress first to show that data, establish that yes, survival benefit is tremendous, and therefore government funding is invited.
So I think in short, what Sir is trying to say is there should be tempered enthusiasm, and at the same time, not everybody should be doing it. It's not a golden ticket where it's one size fits all, and definitely transplant oncology is in its nascent stages in different malignancies, because in colorectal it is different, in pseudomyxoma peritonei it is different, and in desmoid tumors it is different. So you have different stages of the baby trying to get out of the crib and walk. So
That's a good analogy. I like that.
so I think it's something which India should definitely be moving forward in the direction once things are set into place. And most importantly, what Sir was stressing was the about collecting and collating the data, because finally data is king, and data is going to tell you whether this is actually helping you or not.
Absolutely. You got that
So
right.
it's a great pleasure to have a nice conversation with you about transplant oncology and the different aspects and facets of it.
Thank you. Thank you for having me on.